Hi, everybody. Welcome to the next episode of Lessons from the Lab. I'm Devon Rubin from Mayo Clinic in Jacksonville, Florida. I have two guests today that will be joining me together. They are guests that have vast experience in electrodiagnosis and neuromuscular disease. They're wonderful people. I love learning from them, and I hope that you will enjoy this episode and get quite a bit out of this episode from both of them. So sit back and enjoy. Well, welcome to the next episode of Lessons from the Lab. It's such a pleasure to have two wonderful guests with me today. These are experts in the field, have a vast amount of knowledge and experience in electrodiagnosis and neuromuscular medicine. These are two wonderful professors of neurology at Duke University. We have Janice Massey and Don Sanders. Hi, Janice and Don.
Hi.
Howdy.
Thanks for taking the time. It's great seeing you. It's been a while since I've seen you in person, I think. Are you staying cool this summer up there?
Well, in the building, yeah.
Only if we're inside. Yeah.
Only if we're inside, yeah.
Yeah.
How about up there?
Well, I'm south of you in Jacksonville, but it's probably exactly the same, hot and humid, and it makes it good to want to go to work when it's like this outside.
Yeah.
So,
Yeah.
so do you have besides spending your hour with me for the summer, do you have any better summer plans than Lessons from the Lab recording?
Janice?
I have a 3-year-old grandson. I mean, we have a 3-year-old grandson. He's not just mine. And spending time with him, and he particularly likes trucks and building sites. So,
Well, good. That sounds good. Maybe when he's a little older, he'll like Lessons from the Lab.
yes, but not yet. Yeah.
And
We're getting together with our family, our kids and our grandsons in a couple of weeks up in Massachusetts on Lake Winnipesaukee. We go up there every summer. So that'll be our big event this summer.
good. Well, I'm stuck in Jacksonville where we start our resident CNP course we give once a year. It's in July and August, so that starts next week. So so that's going to be my big summer plans for the next 2 months.
Mhm.
But at least we can add this to the education. So yeah.
Well, our fellows start next week as well, and we have introductory lectures that we give to them. So
Yeah.
that'll be part of our summer.
Yeah. Well, as you may know, this is another piece of information, these lessons from the lab that AANEM has been doing. And we share this with our techs and our fellows. It's free on the AANEM YouTube channel and on AANEM podcast. But what I wanted to do, since I have you, is I wanted to present a case to you that we had in our lab and in our clinic a little while ago. And I'd like to pick your brains and see what you think, how you would approach it, see if you think we did things correctly or incorrectly, and just talk through a case. So
Good.
so I'm gonna share my screen, and what I'm gonna do is I'm gonna read this. This it's only 2 slides. I'm gonna read the case for people who are listening, and then I'll pause after I give you the information, see if you have any questions or what you would initially think about this patient. So the patient is a 44-year-old woman who came to us with a presentation of 5 months of progressive weakness. And she noted mainly weakness in both of her legs symmetrically. It was gradual over months and just slowly worsened to the point where she required the use of a cane to walk, for balance, and then eventually she needed a wheelchair for longer distance. And her main complaints were trouble getting out of chairs, getting out of a bathtub. So kind of from a squatting position, she had difficulty. She had some mild weakness in her arms as well. She may have had some slightly slurred speech when she was tired, but that wasn't a big complaint of hers. And she occasionally had some choking on some types of food, but again, not really consistent. And she didn't have any ptosis, she didn't have any diplopia or other bulbar symptoms. She would get winded easily, by her words. So maybe some shortness of breath with activity. And that was mainly it. She had no pain, no paresthesias or sensory symptoms, no bowel or bladder problems, maybe a little bit of lightheadedness upon standing from a sitting position, but really no other major autonomic symptoms. So that's a nice kind of concise. That was basically it. She was healthy in terms of medical problems, didn't have any other systemic medical conditions, had no family history of any type of neuromuscular conditions or a hint of that. And she wasn't on any medication. So
So
you want to see the exam, or do you have any questions from there?
I'd like to ask two questions.
Okay.
All right, since you've given us a mixed picture here. One, what are her tendon reflexes?
Well, I'll give you that in the exam on the next slide.
Okay.
So good question.
And the second question is, does she have a dry mouth?
Okay, good question. She did have a dry mouth. In fact, I took that out of the slide, but she did have it. She did not have dry eyes, but she did complain of that when asked. So I was thinking like you were. This might be easy for you, but that's okay. But here's her exam. And this is just summarizing. I'm not going to give you the details of the grading, but on her exam, it was mainly motor exam findings. So she had symmetric, mild proximal and distal upper extremity weakness. So deltoids, triceps, finger extensors predominantly. Her lower extremities was a little more severe, so moderate symmetric proximal weakness, mainly around her hip girdles, and her quads were slightly weak as well. We did try to fatigue her, so did repetitive arm abductions 25 times, and that did not worsen her weakness. Her reflexes were reduced diffusely. She didn't have Babinski, and she had a normal sensory exam. And her gait was what you would expect with her weakness. She had some difficulty rising, kind of needed the use of her arms. Her gait was a bit of a waddling type of gait, but she was able to ambulate independently. And I didn't stick my finger in her mouth to test how dry it was, but that she did complain about that.
Did she have hard candy in her mouth constantly?
Good question. I don't remember. I don't. Do you pay attention to that when you're?
I have to me, a famous case, a woman that was referred for weakness, rule out myopathy. And while I was doing the examination, I noticed that she was sucking on a piece of candy. And it's not typical for patients to be eating while we're doing EMGs. And so I asked, what's with the candy? And she said, oh, it's what helps keep my mouth from being too dry. At which point I stopped.
Ding,
Ding, ding, ding. I stopped doing the EMG and said, let's do some nerve stimulations here. So that was the tip off in that patient. So
Interesting.
that's that plus the reflexes now are leading me in one direction.
I agree.
So, okay. So,
this.
yeah. So, all right. So if you had this patient that came into your clinic and you're thinking one direction, which I think we're all thinking about, is there more than one thing that this could be, I guess? Or is it obvious we're done, we have the diagnosis? What things?
Well, yeah, we certainly know what we need to do to confirm or exclude the diagnosis, but we're not quite finished yet.
Yeah. So I think, if I was asking, if you were a resident, and I was asking what would be your potential localizations besides a neuromuscular junction disorder, what is there anything else that you think we should exclude?
Myopathy, I presume. I mean, of course, that
Yeah.
may still be a part of what we're secretly thinking.
Yeah. Okay. We won't give away the answer yet, right? So, but do you think the reflexes, if they're reduced, in your experience, does that exclude a myopathy? Or you think that it still could be a myopathy with proximal weakness and
Yes.
these reflexes? Yeah, I think so
Yeah.
too.
But yeah,
Yeah.
we're in the neuromuscular, as you said, we're in the neuromuscular junction. And so the question is pre or post synaptic. And the reflexes certainly go along with postsynaptic process, excuse me, presynaptic process.
Yeah.
Keep me on the right track.
I've tried for a long time.
Because with myasthenia, the reflexes ought to be normal unless there's some superimposed neuropathic process, which is certainly not unheard of. But you didn't say that she had diabetes or any
Right.
other obvious neuropathic process.
So just from a clinical standpoint, I mentioned that she didn't have fatigable weakness on repetitive testing. If you're trying to sort out a presynaptic disorder like Lambert-Eaton myasthenic syndrome, which we're all thinking about, do you do brief exercise and look for changes in the clinical exam? And how comfortable are you with seeing that, or how often do you see that?
Well, if that is what it is, I think we often do, but it's certainly not adequate to make a diagnosis, confirm a diagnosis. And you're going to say something?
I wasn't going to stop you, but go ahead.
And I also would comment that the exam is not very suggestive of this being myasthenia gravis because it's such an unusual presentation. And so that would be right away, that would not be the highest on my list. I certainly would have that in in the consideration for diagnosis, but it's just so atypical a presentation for myasthenia. And the other side of that is that it's a very compelling presentation for, shall we mention, Lambert-Eaton.
When you're testing for facilitation or improvement or whatever term you want to use of clinically, do you test that on reflexes or on the actual muscle power or both, and how do you do that clinically?
I would do both.
Yeah, both.
Both.
Go ahead.
The reflexes and this is true in, forgotten the exact percentage, but there is actually a paper on how frequently do the reflexes facilitate in Lambert-Eaton syndrome. And I think it's around 2/3, depending upon how you do it. I like to do it in the quad because you have the patient seated and then you have them extend, where you do check the reflexes first while they're seated, and then you have them maximally extend the leg for a brief period of time, typically maybe 15 to 30 seconds. And then immediately after relaxation, you hit them with the reflex hammer. And when it's when it's that observation is positive, you know pretty much immediately that you're dealing with a presynaptic abnormality.
Mm-hmm.
Now, testing strength repetitively, I like to use the deltoids and have them do this and then push down and do it again, push down, do it again, do it several times, and then finally say, now give me all you got. And with that final push down, the strength typically will be greater than it was with the first. Now, that observation is not unique to presynaptic abnormalities. Many patients with myasthenia will facilitate to a certain extent. Depends upon how severe their neuromuscular block is at rest. And not only is that true of the strength testing, but it's also true of the nerve stimulation testing. And if you want to do really fancy jitter studies, you can test the jitter at different frequencies or different levels of activation. And classically, you might be able to demonstrate that the jitter becomes less the faster the firing rate. So these are all observations that are underlined.
Yeah, no,
Oh,
I was gonna.
by
I
the
was.
by the physiology at the neuromuscular junction.
Yeah, I was gonna. Oh, go ahead, Janice.
I was just going to say, have been seen.
Have been seen.
Yeah, I was gonna ask you a little bit later about the jitter, but since you brought it up, if you're doing single fiber on a Lambert-Eaton myasthenic patient, and you were to try to see the jitter reduce with higher frequencies, can you do that with voluntary activation, or would that be more with stimulated single fiber?
It would be better with stimulation, but it can be done with voluntary activation just by having the patient do different levels of force,
Right.
And when it's, but again, that's not absolutely diagnostic of a presynaptic abnormality. In occasional patients with classical myasthenia, the jitter will become less at higher firing rates. But if that observation is repeated in several muscles and you get the same pattern, then that is very strongly suggestive of presynaptic abnormality.
Okay. And I was thinking, as you talk about facilitation of reflexes, I was thinking, I can facilitate any normal person's reflexes just by using a tomahawk hammer, reflex hammer, and then a Tromner hammer. So if you have a bad hammer, you can't get reflexes.
Yeah.
So it's a practical point for anyone doing a good neuromuscular exam.
Absolutely.
Use a good hammer, reflex
Yeah,
hammer.
use one with some heft to it.
That's
Yeah.
right. That's right.
That's the Trump. Well, actually, I have an old tomahawk, hardened
Right.
black-headed tomahawk that has a fair amount of heft to it.
Yeah.
And it's as good as a Tromner.
Yeah, yeah, not the cheapo ones that you can get on, get at the dollar store, right? So,
Or used to be given out.
right. All right. Well, good. These are great practical points. So, getting back to this
Oh,
patient.
one more clinical question.
Sure.
How is the eyelid closure? Is the eye closure weak?
Yeah.
Well, is it weak? This is a patient I saw a while ago. So I'm gonna not answer that because I don't remember. But how would that help you?
That's eye closure is abnormal in virtually 100% of myasthenics. No matter what other weakness they have, if they don't have weakness of eye closure, be suspicious.
What about Lambert-Eaton myasthenic syndrome? Can they have bulbar weakness?
Occasionally, but it's certainly not prominent.
Okay. So if there was some weakness of eye closure in this context, it wouldn't completely exclude, you couldn't be sure what this is just based on that.
Well, I'd have to put it in the context of the other things we've talked about.
Okay. You're pretty sure. So if you're so sure then, and obviously patients don't always come in with the textbook presentation, right? So it's not always perfectly clear, but if this patient came in like this, do you think what would you do next? Would you do electrodiagnostic testing? Would you just do antibody testing or both?
Well, if you do electrophysiologic testing, you get the answer quicker than if you do an antibody. But nonetheless, I think that defines the physiology rather than just the serology, which is to me more provides more information.
So in
our clinic, we'd walk the patient over from the clinic room into the EMG laboratory, and we'd have the answer within 15 minutes.
right.
And I don't know, how long does it take to get
If there's a room
available.
Yes.
Yeah.
But, and how long does it take to get antibodies back?
I don't know. It's
A couple of weeks.
Right. No, I'm like you. I think I'm always a neurophysiologist at heart. But there's, I think we would still run antibodies, but we would do the EMG first.
Yes, and I would comment, it is an extension of the physical examination.
Right. So in the Duke EMG laboratory in this patient, what would your approach be?
Rep stim, I mean, first of all, it would be verifying that the nerve conduction studies are relatively normal, meaning that they may not be pristine because of what we're dealing with reduced amplitudes, but just verify that we're not mistakenly going down the wrong pathway. But rep stim is going to be the answer, or pre and post CMAP with exercise.
And when you're doing rep stim, what nerves do you do in this case? So different from synostosis and bulbar symptoms. Do you do distal or proximal or both?
Where the weakness is. I mean, that's always my answer to that question. I want to examine the area that demonstrates the most weakness. So
I guess I asked because in Lambert-Eaton syndrome, like this patient wasn't weak distally, as weak distally as proximally, but I think you have much more experience than I do, but many times it's the distal muscles in Lambert-Eaton syndrome that I've tended to see increment and changes.
Yeah, we did a comparison a number of years ago, along with Richard Tim, on just that question, which muscles are most likely to be abnormal in Lambert-Eaton syndrome, and are the proximal muscles ever abnormal when the distal muscles are not? And the answer is hand muscles are much more likely to be abnormal in every patient. In fact, a decremental response to low frequency stimulation was the most frequently seen abnormality in Lambert-Eaton syndrome. And this was mostly true in the ulnar hand muscles. Whereas the trapezius was abnormal with either a decrement or with facilitation, post-activation facilitation in a much lower percentage of patients. Now, my favorite question for the fellow in a situation, well, most any situation, is if you could only do one test, what would that be and why? And the answer in this patient is, as Janice said earlier, I'd do a resting CMAP in a warmed hand muscle, and then would have the patient activate for 10 seconds with maximum contraction and deliver a supramaximal stimulus immediately after the end of the contraction. And then I would see, undoubtedly, I would see, first of all, a low amplitude response in the resting CMAP. And then I would see at least, I used to say 100%, now I say 60% facilitation in the post-activation CMAP. And that to me is essentially diagnostic in this patient. So I wouldn't need to do anything else, but I would.
Yeah, no, that's a great point. And so it gets into, you're kind of reading my mind of a few questions, and I'm going to ask you now before I show you the waveforms. You said 60% increment. Is that what your cutoff is now? I know there's evidence, there have been some papers looking at that compared
Yeah, there have been a dozen papers looking at that question.
to.
The critical question is, in how many muscles do you see it? If you see facilitation in more than one muscle, then that is very strong evidence for Lambert-Eaton myasthenia. But there are reports of patients having as much as 400% facilitation in classical myasthenia. And I know one paper that showed a significant facilitation in a patient with carpal tunnel syndrome in the median nerve. So, abnormal neuromuscular transmission is not unique to autoimmune diseases of the junction. There you do see increased jitter, and you do see decrements. Well, every patient with ALS has a decrement in some muscle. So neither of the two junctional tests are absolutely specific for a disease, but they're specific for abnormal neuromuscular transmission.
Do you think that exercise is better at bringing out facilitation than high frequency stimulation?
Yes, I do. And it's better tolerated. You're more likely to be able to complete the test.
Yeah, and the patient's more likely to come back and see you if you just do voluntary activation. Again, we did a comparison a number of years ago on that very question. The answer was, if you do the test right and time it appropriately, then maximum activation, voluntary activation is just as good as high frequency stimulation.
And this was your paper, I think, from that looking at voluntary contraction versus 20 hertz stimulation. That's what you found, that higher percentage had facilitation with contraction, but others have showed the opposite or suggested the opposite.
I'm sorry.
Other
papers have suggested the opposite. So yeah. So
depends on how you do it.
Have you done high frequency stimulation on yourself?
He's done it on me.
Have you done it on him?
No.
No, but Ed Lambert did.
Wait a second. So, but you've had high frequency stimulation.
Yeah.
Okay. I was going to say you've gone for all these years and you've never experienced it?
Oh, I've had it done. As I said, all the fellows at Mayo, when I was there, had to have everything done that Ed wanted to do, including maximum voluntary contraction for 30 minutes. Try that and then use the arm.
Yeah.
Ed did that sort of thing on every fellow, not just to get data, but make sure that you knew what you were doing when what the patient was experiencing.
I was just at work at Mayo in Rochester a couple weeks ago, and we were showing the fellow high frequency stimulation. I was working with a colleague up there at the end of the day, and I said, I don't. We were talking about 20 hertz versus 50 hertz versus 100 hertz stimulation and the pain associated with that. And I said, I don't think 50 and 70 hertz would feel much different. So we did it on me, and it did for me. 70 hurt more than 50, and that was only for half a second. I did it for half a second, and at sub maximal sub threshold stimulation. So I don't like that feeling.
So you organize that yourself.
Yeah, we were just playing around at the end of the day.
Yeah.
Just
I
having
don't
fun.
think you could impose that and require trainees to undergo that these days.
No, this fellow wanted to see what it felt like. So
Good on him.
right. So okay, so let me just show you the nerve conductions here.
Janice just reminded me that she fell asleep while I was doing that on her.
Really?
During a demonstration at the AANEM board at a workshop.
Oh gosh.
We had just adopted our second, I think it's our second baby. So the prequel to that is that I was really sleepy because of coming from home,
Yeah. I could see falling asleep during single fiber. You probably both had plenty of people over the years do that, but high frequency stimulation, you must have been really tired.
Yeah.
One other question before I show you this. So one thing that comes up when doing, I know we don't do 20 or 50 hertz stimulation often, but if we do, you might get an increase. We might get pseudo facilitation, right? So an increase in the amplitude, decrease in duration with the same area. Is there a cutoff that you're aware of that would say this is pseudo facilitation versus true facilitation? I mean, I guess it's not a cutoff because maybe you can describe how you would separate out pseudo facilitation being a normal phenomena from true facilitation with high frequency stimulation.
Well, I wouldn't try to use a number. I'd look at the difference in the area versus the amplitude, as you say, and see whether the change in area and amplitude were pretty much the same.
I'm going to show you, this is not from this patient. These are two different patients. I will get to this patient in a moment, but this was a patient with with Lambert-Eaton myasthenic syndrome, just showing the bar histogram of the amplitude and then the area both increasing substantially. But this was a patient, I think, see if you would agree, that had pseudo facilitation. The amplitude goes from the amplitude increases 2.6%. And the area, I don't think this is measured correctly, but if you just look at the waveforms, the duration kind of shrinks and the amplitude increases a little, but the area doesn't. Anyway, I don't know. I thought it was interesting. Do you know why we get pseudo facilitation? The mechanism?
I know there are a couple of I think these are mainly hypotheses. One is that the discharges of the individual muscle fibers or motor units becomes more synchronized, and they fire together at the same time and summate. That's one. And
I don't remember.
I've forgotten the other one. It has something to do with basic physiology of muscle contraction. And I don't know the answer Which
Well,
one?
I don't either. When I was in Rochester, we were having this discussion and we were looking in some of the old medical journals and looking it up, and we couldn't find a good answer. So,
Yeah, I think Alan McComas is the one who hypothesized well, he hypothesized one of those,
yeah,
but I don't remember who did the other one.
right.
It's
All right, let me show you what this patient actually had, what the waveforms look like. So, can you see these okay?
not yet. Are you
Um,
sharing?
have you not seen my screen at all?
No. Oh,
Wait.
hang on a minute. That's my problem.
So I've
Uh,
been talking and showing you things, but you're not seeing it.
Yeah,
well,
Well,
your
you're answering the
description,
questions really well without seeing what I'm showing
well,
you.
your description was so yeah, there's a way I need to sit. I've got two monitors going here and I'm
Okay,
not,
it's okay. It's okay. I can just explain. So I'm gonna just you don't have to spend time trying to figure it out. But I'm gonna tell you the fibular motor. So this is normal conduction studies, the routine conduction. So fibular motor amplitude was low, zero point 0.5 with the normal velocity and latency. Tibial motor amplitude was zero point 0.4, so it was low with everything else was normal, velocity, no dispersion or anything else. The sural was normal. The median motor amplitude was 1.7 millivolts, so low. And the ulnar motor amplitude was 0.6 millivolts, so low, very low. And the sensories in the arm were fine, were normal. And I think you said, Janice, earlier that typically you see low CMAPs in Lambert-Eaton syndrome, right? Yeah.
yes,
So then we did repetitive stimulation on the EDB, and you can't see this, but we gave, and this is a question I have for you. So what we do in our lab is we give 4 stimuli at rest for both myasthenia or any neuromuscular junction. We do 4 stimuli at 2 hertz, 3 times for baseline. And in this patient and the EDB, the decrement consistently was about 15% in amplitude and area from the EDB at 2 hertz.
was that 15 or 50?
Yeah, 1.5.
5? Uh-huh. Okay.
So the question for you is, I believe from what you've published, so I think what you do in your lab is you give more than 4 stimuli. And so how many do you give and what's the advantage of giving more?
Well, I give 9 or 10, depending upon which uh, train duration is in the specific machine. And you do that in order to see the envelope of the waveforms. The classic envelope for myasthenia is the saddle-shaped curve. And you won't see that if you only give 4 stimuli. You need to give at least 9 in order to see that true saddle shape. And I give 2 trains at rest at 9 or 10 hertz. And I want to see that the 2 trains are superimposable. In other words, that they are identical, and that you get the numbers, you get the same numbers in both trains. And that's a quality assurance observation.
Mm-hmm.
And then typically I would deliver the 2 trains at rest and then after maximum activation. Now, if I want to demonstrate facilitation, then I only use 10 seconds of activation. Because if you use longer duration activation in a presynaptic abnormality, you can go from the facilitation phase into the exhaustion phase.
Mhm.
during the activation. In myasthenia, you're trying to demonstrate for the exhaustion. So I use 60 to 90 seconds activation if I'm trying to demonstrate myasthenia. And again,
Do you ever do both? So if you had a low amplitude, do you do 10 seconds? You're not sure which it is. You do 10 seconds and then exercise for a minute afterwards, or not usually?
not usually, but I'd never say never.
Okay. And the getting back to the train number, so is it true that if you're only looking at maximum degree of decrement, that you're going to see that by about the fourth or fifth stimulus at low frequency?
Are you leading me on here?
No, I'm just seeing if I'm wrong, if I'm incorrect.
Yes. Actually, the the stimulus with the lowest amplitude of a train differs in myasthenia and Lambert-Eaton. In myasthenia, you have the saddle-shaped curve so that the maximum decrement is in the fourth or fifth response. Whereas most patients with Lambert-Eaton will have a progressive decrement. The decrement will become greater at the end of your train of 9 or 10. And you weren't leading me on there, were you, with that question?
Well,
Because
that was the follow-up question, and I know you can't see my screen, but I'm showing your paper
okay.
review,
That
showing
was
the
my,
showing the picture.
Show it to us so we
Yeah.
can remember.
yeah,
So, yeah. So you're saying, and I'm just pointing this out for those who are watching in this picture of the LEMS, that you see this big drop at by the fourth, to the fifth or fourth or fifth shock, but then it continues on and becomes slightly lower with continuation. And myasthenia, it comes up.
yeah,
Yeah. Okay. Well, we didn't follow your rule. We just did 4 stimuli but then we had them exercise for 10 seconds and the amplitude went from 0.61. This is just the first shock amplitude, 0.61 to 1.0 or 1.1. So it did increment. I think if you calculate the increment, I did this earlier, it was about the increment, not, I know there's a different in formula with facilitation and increment, but it was, I think, 170% increment there.
yeah,
And
1.66.
yeah, and then we did the same on the ulnar ADM. The decrement at rest at low frequency was 30%, 25 to 30%. And then after 10 seconds of exercise, the amplitude went from 0.7 to 2.8. So really jumped quite
Yeah.
up. I'm showing these pictures for those who are watching, and you could see the big jump in amplitude.
Yeah, the ADM is the muscle that usually shows the most change after active. Well, the lowest amplitude to start with, and the most facilitation after activation. And there's a inverse relationship there. Obviously, the lower you start, the more the facilitation can be. And the EDB only rarely showed the same degree or close to the same degree of abnormality as the hand muscles did. And as I mentioned earlier, the shoulder, the trapezius, only rarely showed significant facilitation or decrement.
And the other question in your experience is when you do the brief exercise and you get the facilitation, how long do you think that typically lasts for on electrophysiology? Is it quick or
Yes,
yeah? So if you don't,
it reflects that rundown during a train of 10.
Mhm.
And so in a train of 10, what's the duration of the train?
Yeah,
At 4 per second.
Right.
That's how it falls off within the first 10 seconds.
So if someone has them exercise and then the stimulator slips off the nerve and they have to get it off the ground and they have to put it back on and it takes a minute and they finally re-stimulate, that facilitation may have disappeared.
Yeah.
Yeah.
You have to deliver if you're doing just a pre and post activation stimulus, you need to deliver that post activation stimulus immediately after the end of the activation.
Yeah.
As
Okay.
fast as you can.
So the last thing I'm going to show you, well, two more things, and I'm going to test you both here because since you can't see the screen, I'm hoping this will play and you'll be able to hear. And I'm going to play. So we did a needle exam on this patient also, and I'm going to play a clip and just tell me if you can't hear it and see if you can. I know it's hard over the video. You may not be able to hear well, but see what you think.
Jitter blocking.
Yeah. Okay. This is with the concentric, but
Yeah.
yeah, you can hear the.
What's your low frequency filter?
This was just routine concentric, so it was 30 hertz. And
Yeah.
then this you'll love the sound of this. That's the single fiber clip showing jittering walking. Yeah. Now, in this patient, if you did a routine EMG and you found jiggle and unstable potentials, would you do single fiber?
Hopefully, I would.
Um,
I like to do it, but you don't have to.
yeah.
I knew that would be your answer because it's fun, right?
What I do and what I have to do are different. But, there's so much fun doing jitter studies that, yeah, I do that. But what you've done here is you have shown the value of learning how to do jitter studies, which is your ear becomes trained to hear unstable motor units. And the way that you can confirm that they're unstable is exactly what you just did. Turn the low frequency filter up to 1,000 if you're using a concentric needle. Turn it up to 1,000 and then trigger on a motor unit and turn your sweep speed up so that you can see the individual components of that filtered motor unit potential. And that will confirm with your eye what you heard with your ear.
Mm-hmm.
And
right.
Learning to hear these unstable components in the concentric, when you're doing your routine concentric EMG, is a major talent, if you will. And
may I say tool rather than
tool?
Tool.
Okay, but all right, sure, okay. You're right. It's something you learn.
It's useful.
Yeah,
it's
it's very useful. Yeah.
And besides, and I agree, I know this is a good tool in many patients, especially myasthenia. We need this tool because the routine studies aren't very abnormal. But if you have a concentric needle EMG that shows unstable motor units, your single fiber is always going to be abnormal, right?
Yes.
So if someone were rushed or didn't know how to do single fiber or rushed, it wouldn't be imperative that they do it in a patient like this when you have those motor unit potentials, right? Would you get any more value besides having fun doing a single fiber?
Um, Only a very esoteric value, and that is it could then go into the database.
Okay.
But we emphasize that among the features of motor units that you need to describe when you're doing concentric EMG, the amplitude, the duration, the polyphagia, and the stability.
Right.
So always include a comment on the stability of the motor unit potential when you're doing a routine concentric EMG.
Do you think that you can assess stability adequately when people just do interference pattern and have the patient contracted a strong contraction?
Uh, you can better assess it at less than maximum
Yeah.
activation, but it depends upon how well trained your ear is.
So how I'll put you on the spot. How many if what's the limit of motor units firing that you think if you had 10 motor units firing, could you tell that some were unstable if they were all 10 if 10 were firing at one time? I would say yes. I'm going to answer for you. I say you both would yes, absolutely.
Yeah,
It depends on the severity of the abnormality, of course.
Mm-hmm.
yeah, it depends upon which population of motor units are abnormal.
Mm-hmm.
Is it the low threshold ones or the moderate threshold ones? You can't assess visually the waveform of motor units when they're more than 3 or 4 firing it during an activation.
Mm-hmm.
So most of the information is in the low threshold motor units.
Right. Great. Well, oh,
Could I make a comment about, um, we all want to get the diagnosis, and the easiest way to get the diagnosis and move on. But there are times when patient circumstances will change over time, and it is helpful to have some core knowledge uh, documented from where they started when we first saw them. And so I would put in a plug for recording the initial findings in a way that is at least as quantitative as you can make it, and keeping that
mhm,
and remembering that that is a tool that you might need to use in the future.
right.
And it does not come up very often, but on occasion, it is useful to compare later studies with, um, um, those studies.
Yeah, we do.
Sometimes after therapy, patients may have reasons to think they are no better, or occasionally even the other way, but usually it would be in that circumstances where it's reassuring to repeat the study and be able to demonstrate that indeed there is improvement. So
Right.
that's
Right.
clinical
We
opinion.
do that. We do that with standard nerve conduction studies. We do that with rep stim. So why not do it with single fiber too? Right. So, well, this is terrific. There's so much information here. I think the other point, a very simple point, I'm sure we would all agree, is the importance of having an index of suspicion of this disease, right? Because I know here, and I'm sure in many places, and probably maybe not at Duke, but patients come in and the techs or someone does just the routine conductions and aren't thinking about this and aren't thinking about the clinical scenario. And then once you think about it, then you do everything we've been talking about. But if we don't have that index of suspicion in someone with proximal weakness or limb weakness, it won't be done. So I think
Yeah,
that's
if the tech comes in and says, I'm having trouble doing these motor nerve conduction studies because the supramaximal stimulation gives different amplitudes. And, your ears perk up at that point. You said, let's go do a rep stim.
Mhm.
or where I feel really good is when they say, yeah, I noticed that. So I just decided to do rep stim and look what I found. So when
Yeah,
they're
Yeah,
thinking about it, then you feel good. Like you've
yeah.
taught them, they know what they're doing. So that's
yeah.
always a great feeling. So, well, this has been fantastic. It's already been an hour. It went so quick by so quickly. And I know you have such a great amount of experience and I appreciate you sharing it with me and with everyone who's going to be watching or listening to this. To learn from both of you is just a tremendous opportunity. And I look forward to being able to learn from you again somewhere in the future.
Great. it's been a real pleasure.
Yes, yes.
Well, thank you. And I hope you have a great summer traveling and stay cool and you take care of yourselves.
You too.
Thank you, Dan.
Bye-bye. I hope you've enjoyed this episode of Lessons from the Lab. What a wonderful two guests to have, Drs. Massey and Sanders. They really have such a vast amount of experience in all of neurophysiology, but particularly in assessing patients with neuromuscular junction disorders. There's so many different pieces to this case that I think are critical to remember and think about when we're evaluating patients with progressive weakness. As we all said, remember to think about the condition, think about Lambert-Eaton myasthenic syndrome or any neuromuscular junction matter disorder for that matter. It's important to pay attention clinically and the subtleties of the clinical examination that can sometimes help you identify a disorder such as LEMS. And then, of course, pay attention to the intricacies of the electrodiagnostic testing that we may not perform on other patients. So not only repetitive nerve stimulation, but the type of repetitive nerve stimulation, the type of exercise to perform, how long to perform exercise, whether we should perform rapid stimulation, how many times we should give a stimulus during repetitive stimulation. And while there are no absolute right or wrong answers, there's different cutoffs or criteria that we might use. I think Drs. Massey and Sanders really honed in on the details of how do we interpret these studies and make a diagnosis with as much confidence as we can. So I hope you will take these points home, use them in your practice, and I look forward to having another episode in the near future. Bye-bye.